Hi Mary, my name is Brian. They've ordered for you to have us remove that breathing tube, so I'm going to go ahead and extubate you. Let me sit you up really nice and tall. Go ahead and put a towel on your chest. It'll help catch that tube when it comes out. I have my Yankauer suction. I have my syringe. I have my subglottic suction catheter, and I have a nasal cannula that is on and ready to go. Nasal cannula setting is adjustable according to the previous settings. This does not fit around the front of his face and wrap around his ears, so I'm just going to place it on him around the back of his head. So just to let you know, I have my suction here. Let's go ahead, O2 breaths. Test my suction. Mary, you're going to have a big cough here. I'm going to clean out your lungs. Meet resistance, pull back, suction, suction, suction. Support the tube, suction, suction, suction. Pull out slowly. Remember, at this point your patient should be awake and responsive and ready to get rid of this tube. I'll grab my subglottic suction. Remember, this is clean. You do not need sterile. Your goal is to get secretions that are above the cuff, so you're just going to thread it along the side of the tube until you meet resistance, and hopefully that is in and around or near the cuff. Again, you're going to suction with the thumb port. You may need to do it intermittently because you are now connecting with the tissues. So you're going to clear out the subglottic secretions smoothly, quickly, and with purpose. Again, if you need to suction out the mouth a little bit more, you can use the Yankauer, but you're basically getting this ready to use after the tube comes out, because you're going to instruct them to cough. Going to have my syringe ready and available. I will go ahead and loosen up the tube. Again, I have I hit the O2 breaths so I can hyper-oxygenate the patient. And so this will just come around. And then we can go ahead and disconnect the tube itself. You want to make sure that you keep it very, very stable. The pads you'll have to peel away from the skin because they can tear the skin, especially if the patient's skin is fragile. Alright, Mary, on the count of, when I ask you to, I'm going to have you take a nice big deep breath in, and then we'll get that breathing tube out. Big deep breath. Good. Give me a nice strong cough. Go ahead and clear the secretions. Have them close their lips over it. Can help facilitate that. I'm going to put the ventilator on standby, and then I'm going to proceed to put the oxygen on Mary. Mary, how does that feel? Can you say your name? You want to verify that they can use their vocal cords. And then you're going to go ahead and have the patient cough again. Nice big strong cough. Cough, cough, cough. That's good. Hopefully, if there were any secretions that dropped when you extubated, that they were able to clear them themselves. I'm going to listen to the upper airway, listen to the neck for stridor. I'm going to listen to breath sounds bilaterally. I'm going to ask if the patient can verbalize, and then I'm going to instruct the patient just to rest their voice, because hoarseness is one common complication or observation, really, that self-resolves after time. So I'm going to monitor the SpO2 on the liter flow, their heart rate, their respiratory rate, and how they tolerated the procedure itself. So again, I'm going to ask them to take a deep breath, and as they're beginning to take a deep breath, I deflate the cuff and pull out the endotracheal tube, having them cough right after the procedure is done. Some therapists like to have them take a deep breath and cough, and they'll pull out that tube during one or the other maneuver. And that way the cords open up during inspiration and they open up during the cough. So the chances of you pulling out that tube as the cords are open is greater if you encourage them to take a deep breath and cough as soon as the tube comes out. So lots of coughing, make sure they can clear their airway, and make sure they're stable afterwards.